This is the rehabilitation case study on the ACL by Callie Scory and Cassandra Hedinger. This is our patient, Tara. She's a 30-year-old high school health teacher as well as a girls' high school varsity soccer coach. She runs about 10 miles a week and plays on a recreational soccer league team 2 times a week. She also enjoys playing with her 2-year-old son. During our initial evaluation of the patient, we determined that she came into the clinic 5 days post-ACL reconstruction surgery. She described that during her varsity soccer practice, she was participating in a team scrimmage, and while turning to cut the ball, her right knee buckled underneath her, at which point she heard a popping sound. Her chief complaint was right knee pain, with sharp pain primarily at the incisions, as well as some constant achy general knee pain. She doesn't have any pertinent past medical or family history. She is currently on her last few pills of hydrocodone, but alternating ibuprofen and Tylenol. The ACL is a ligament in the knee called the anterior cruciate ligament. This ligament connects the posteromedial corner of the lateral femoral condyle to the anteromedial intercondyloid eminence of the tibia. The ACL is essential for normal knee function as well as stability. The main function of the ACL is to prevent anterior translation of the tibia on the femur, but it also prevents excessive internal and external rotation of the tibia as well as hyperextension of the knee. So since our patient had a patellar tendon autograft done to surgically reconstruct her ACL, there are many factors that we will need to consider in her rehab plan. Our post-surgery concerns include excessive swelling of her lower extremity, specifically around her knee joint, as well as extending distally to her ankle joint. Also, we need to be aware to watch for infection of the surgical incisions. Additionally, since she had a patellar tendon graft, we must avoid any resisted knee extension throughout the first 4 weeks to protect the graft. So normal ACL reconstruction guidelines take about 9 to 12 months to return to play. Our goal, since she is a younger, active woman, would be to have her return to play in about 9 months. So our first phase of rehabilitation is going to last about 4 weeks. In the beginning, we want to focus on the patient's pain as well as swelling stemming from their invasive surgery. During this phase, you're going to be doing a lot of modalities on the patient like RICE, ultrasound, and massage. But you also want your patient doing some exercise. To avoid swelling in the ankle as well as keep the blood circulating throughout the lower leg, the patient should perform ankle pumps. For the ankle pump exercise, you're going to have your patient laying supine on the plinth. Their ankles are going to be slightly off the table. You're going to have them pull their ankle into a dorsiflex position and subsequently have them plantar flex. They're going to repeat this motion. So this exercise should be performed multiple times throughout the day for about 2 minutes each. And after managing the patient's pain and swelling, we want to start our patient early on regaining lost range of motion. Knee extension is the first motion we are looking to restore. An exercise to help in the regaining of knee extension would be the quad sets because we're looking to regain our quadricep strength. For the isometric quad set, the patient is going to be in a long sit position. They're going to contract their quadriceps, creating a visible superior movement of their patella. This contraction should be held for about 5 to 8 seconds, followed by a gradual decline into full relaxation. This exercise can be performed 10 to 12 times, 3 times a day. During this phase, we also want to start increasing the patient's knee flexion as well as have the patient engage in exercises that activate their core muscles as well as help maintain their cardiovascular fitness levels. So during our second phase of rehabilitation, it's going to span about 4 to 8 weeks. In this phase, we want to focus on the completion of regaining all of our patient's lost range of motion, specifically in knee flexion. An example of this would be the standing quad stretch. In this exercise, the patient should hold their stretch for approximately 30 seconds and repeat multiple times a day. Nearing the end of phase 2, we want to be sure that our patient can maintain her balance, which will be necessary for her during her daily activities. An exercise the patient can perform in the progression to attain balance goals would be the eyes open double leg squat with mirror feedback. To perform the double leg balance with a foam pad and visual feedback, the patient should stand shoulder width apart on an Therex pad. The patient can then perform a squat while looking in the mirror for visual cues for self-correction. For the standing quadricep stretch, The patient should stand with their glutes to the table. Their knee should be flexed and the dorsal part of their foot resting on the surface of the table. The patient should try to pull their foot into their buttocks. As with every phase of the rehabilitation process, exercises that engage the core and focus on cardiovascular activity are vital for return to play. So phase 3 of the rehabilitation process will span from about week 8 until about 6 months. In this phase, we want our patient to regain the majority of their strength. It's important to start with regaining quadriceps strength, but simultaneously the patient should also try to regain all lower extremity muscular strength, specifically in the glutes and hamstrings. Towards the middle and end of this phase, we really want to start our patient on their early plyometrics as well as their early functional drills. An example of an early functional drill would be soccer toe touches.
For soccer ball toe touches, the patient is going to start off standing with a soccer ball out in front of them. Then they are going to place the toes of one foot on top of the soccer ball. Then in a quick pace, they are going to alternate the toes that are on top of the soccer ball.
And then for our early plyometric exercise, we could do a double leg forward hop.
For the double leg forward hop, the patient is going to start standing with the feet shoulder width apart. Then they're going to quickly concentrically contract into a partial squat before they explosively jump and hit the next pad.
So phase 4 of the rehabilitation process is going to span from about the 6-month mark until 9 months, but it's important to recognize that this could very well continue up to 12 months or even longer for the patient to be completely healed and back to play doing everything that they need to do. In this phase, we really want to focus on getting our patient ready to return to play. Through this, we're going to use late stage plyometrics, keep with the endurance. We're going to have them move on to intense running as well as sport specific and late functional activity. An example of a late functional activity would be juggling.
For tuck jumps, the patient is going to start with their feet shoulder width apart. For tuck jumps, the patient is going to start with their feet shoulder width apart. Going to use their head, chest, thighs, and feet to keep the ball from touching the floor.
An example of a late stage plyometric would be tuck jumps.
For tuck jumps, the patient is going to start with their feet shoulder width apart. Then they're going to perform a quick concentric contraction into a partial squat, and then explosively jump up, bring their knees up to their chest.
All right, so it's important to know that to fix an ACL, you have both operative as well as non-operative treatment options. For the operative, you're going to look at, you have both accelerated and conservative. Accelerated is going to be for your top of the line athletes, and they're going to be back in about 6 months. This is probably about 5% of the population, as most people will be in the conservative, which is 9 to 12 months return to play. So when we're gonna do an operative treatment would be when the athlete has a complete tear. A pros of this would be that they're going to have a full return to play and no sport restrictions. They are looking at that 9 to 12 months recovery time as well as scarring from the surgery. With the non-operative treatment, you're looking at partial tears and people that are going to be willing to give up high impact sports. The negative with non-operative treatment is that usually most people have to have surgery later on anyways because the instability of their knee, they basically have no ACL. And so they need to get that corrected at some point in the future. Here are our works cited pages.